Good afternoon, everyone. Thank you for joining our session. Today we have with us Dr. Matt Evison from Manchester University Hospital NHS Trust, and he would be looking at talking about the value of technology interventions in earlier diagnosis of symptomatic lung cancer, particularly talking about getting the diagnostic part of the pathway right. And we are very pleased to have you here, Matt. Over to you, and look forward to learning a lot. Thank you.
Okay, great. Thanks very much for inviting me here to talk. So I'm a chest physician in Manchester, and I'm the lead clinician for our Cancer Alliance. So I've got responsibility for the cancer pathway in Greater Manchester. And I'm going to talk about earlier diagnosis, which is it's the top priority for anyone trying to deliver lung cancer services. And the reason being, we talk about pandemic a lot, but we've been in the midst of a lung cancer pandemic for a long time. So it's the single biggest cause of preventable death and the single biggest cause of cancer death. So it's responsible for nearly 2 million deaths across the world every year. And that's about 20% of all cancer deaths. So there's no other cancer that causes more deaths than lung. And the reason being, so this is UK data, the 5-year survival if you're diagnosed at stage 1 in the UK, and this is from 2020 data, so very live data, your 5-year survival is about 57%, but at stage 4 it's 3%. And sadly, the proportion diagnosed at those two stages is in completely the wrong direction. So nearly half of all patients diagnosed at stage 4 and just 1 in 5 diagnosed at stage 1. So when the NHS long-term plan tells us that we have a responsibility to get to the point where we diagnose 3/4 of all cancers at stage 1 and 2, lung is the biggest challenge by far to try and achieve that challenge. And in Greater Manchester, it's a significant problem. So Greater Manchester is a population of around 3.2 million, and we have between 2,500 to 3,000 cases of lung cancer a year. And there are high areas of deprivation which go linked with tobacco dependency. And very sadly, both tobacco dependency and lung cancer disproportionately affects the poorest members of our communities. And on the right-hand side, the graph from NHS England, it sets out the reasons why people in the most deprived areas live, why the more affluent members of society live longer. And you can see there are groups of diseases here together, like cardiac disease. Lung cancer stands on its own as one of the biggest contributors to the difference in that survival outcome. So if we're going to address health inequalities, and if we're going to address those cancer outcomes, lung's got to be the priority. And again, in Greater Manchester, this graph's from Public Health England, where they set out the causes of premature death. So Public Health England will say you've died prematurely if you die before the age of 70. And this sets out the causes of premature death in Greater Manchester. So the bar in red is lung cancer. It is the single biggest cause above heart disease, lung disease, stroke, often many of those combined. So we'll often get challenged when we're coming to talk about how do we address lung cancer, how do we improve the pathway? And we get told, well, how do I improve A&E waiting times? How do I improve? Everybody is asking me for more. But we have to prioritise certain areas, and so this is a really powerful an understanding of why lung cancer needs to be prioritised. So we have to have a focus on promoting earlier diagnosis. And there's lots of interest in lung health checks, which is brilliant. It is going to change things, screening the high-risk asymptomatic patients. And we're all behind it as a community. But we have to realise that will diagnose around 20% of lung cancers. So 80% will still present via a symptomatic pathway. And if we're going to achieve those NHS England standards, we have to have just as much critical focus on the symptomatic pathway. And there's a lot in there. we know that there are barriers to presentation. I'm going to show a bit of data we've got from Greater Manchester on that. We know a third of people have been to primary care 3 or more times in the months leading up to a lung cancer diagnosis, where we have the opportunity to intervene. And chest X-rays, I think, get overlooked about how critical they are. They will always be at the cornerstone of lung cancer diagnosis in the symptomatic pathway. Some people say if they were invented now, they wouldn't be brought into modern day care because of some of their limitations. But they are here to stay, and so we have to think about how we optimise them the best. Over half of all symptomatic lung cancer cases are diagnosed on chest X-ray. But a good proportion of people with lung cancer will have a normal X-ray. We can take false reassurance from a normal chest X-ray. And we are in the midst of a radiology and healthcare crisis at the moment. And delay adversely affects outcomes in lung cancer like no other pathway. It's the most biologically aggressive solid tumour that there is, and days matter on the pathway. And I think it's really important to focus in on how important chest X-rays are. So this is some work that was done in Leeds, where they did everything they could to increase the amount of chest X-rays being done in people that had persistent chest symptoms, through public awareness campaigns, through a self-referral chest X-ray pathway. So a patient could attend a hospital and just have a chest X-ray with no referral whatsoever. And that showed they increased chest X-rays by about 80%. So a big volume of work, but it showed the biggest stage shift in lung cancer we've seen outside of a screening trial. So a nearly 10% increase in stage 1 with the same reduction in stage 4, shifting patients forward. And we can't underestimate the importance of what it is to get a person who has symptoms to seek help. And there's huge barriers to this in how the public perceive symptoms and suppress their importance as a regular cough, or how they use previous experiences that coughs just go away, or how they interpret their own individual risk of developing lung cancer. Most tragically is that the public have been bombarded with the thought that the NHS is overwhelmed, and that their cough that they've had for a few weeks is not worthy of what is happening to the NHS. And so we've got real things to overcome. So we've got public perception about and their response to symptoms that could be caused by lung cancer. We don't do enough chest X-rays. If we did more, we'd pick up more lung cancers in symptomatic patients. There are limitations to chest X-rays. We could be reassured by a normal one, and we have really significant capacity issues. But we know what needs to happen. The getting it right first time, the National Specialty Report for Lung Cancer, and the National Optimal Lung Cancer Pathway has told us we have to report chest X-rays in 24 hours. And if you've got an abnormal chest X-ray that looks like lung cancer, you need a CT within 72 hours of that chest X-ray. There are metrics in a crumbling system that is trying to keep A&E alive at the front door, and with every other cancer pathway trying to get its imaging through. So that's what we're facing as lung cancer teams trying to deliver this. So I think we need a multifaceted approach about how to address this. It isn't going to be one thing. I think we will make incremental gains at every point in the pathway if we're truly going to do something transformative. So in Greater Manchester, it's on our responsibility as an alliance to develop that strategy. And we've produced this document about promoting earlier diagnosis in symptomatic patients. And it tries to bring in all those aspects. So if we think about starting with a patient in the community that has had a cough for 3 weeks and it's caused by lung cancer, how do we get them to a chest X-ray, get the X-ray reported quickly and into a CT scan that's reported quickly and in front of a clinician like myself? We have to run public awareness campaigns that overcome some of those barriers. And the insight that I showed you is from our focus groups with patients in Greater Manchester. And we've designed our awareness campaigns to try and overcome those barriers. We need a primary care education package. So we've got Gateway C, which is a primary care education platform that delivers modules on earlier lung cancer diagnosis, training AHPs to request chest X-rays. So the primary care community is now a very varied workforce. We're doing direct access, so patients can turn up to an X-ray department and have an X-ray without a GP referral. And once that X-ray is done, how are we thinking about getting that report done as quickly as possible? And that is where the potential for AI comes in that one part of the pathway. We still need to think about what happens with normal chest X-rays, but that person's still got lung cancer. How do we safety net? How do we promote referrals? And how then, from the abnormal X-ray, we move through to a CT scan and fast reporting. So that is the collaboration we've developed with Cure AI, with AstraZeneca, with Greater Manchester Cancer, about deploying an AI platform, but deploying it on a regional scale to try and address the issues we've got. So 97% of NH trusts are reporting backlogs with chest X-ray reporting, most reporting up to 3 to 4 week problems. And 3/4 of trusts are outsourcing because of those delays. And what's been a big driver is the HSIB, so the Healthcare and Safety Investigation Branch, who released a report this year about missed lung cancer diagnoses on chest X-rays. It's quite a powerful report. It talks about the reasons for missed lung cancers on X-rays, the errors that occur that could potentially be supported by automated machine learning, and the advice to the cancer system about making sure we improve our safety netting and that we improve the validation and implementation of AI. And that safety netting thing is really important. There's good data out there that if we encourage GPs to refer on the cancer pathway, the risk of dying from lung cancer in that area goes down. So we have to push up referrals. So the QXR platform, the AI interpretation of chest X-rays, looks for around 30 different chest X-ray abnormalities. It's been shown, we've heard in a talk just given just before by my colleague, that it's got good data behind it of its diagnostic accuracy. And so we pick out a couple of things about how these could be really beneficial for our patients in our region. If we can immediately identify X-rays that are suspicious for lung cancer, it puts them to the top of the pile for reporting. And we can move that direct access to CT pathway, the 72-hour pathway. It's going to drive that. But there's also the safety netting, the automated reporting. We can add an automated sentence about 20 to 25% of lung cancers patients with lung cancer will have a normal X-ray. Do not be reassured by a normal X-ray. You should refer on the cancer pathway if there's remaining suspicion. And so these are our key objectives. With one of the good positions we're in Greater Manchester is we have a single PACS platform for the region. That's 10 different acute care trusts. So Sectra PACS, we all use the same PACS and our same imaging. So we have the ability to deploy this technology on a regional scale. And that really is our first objective. Is it feasible across 10 different sister hospital trusts in the real world to deploy this platform? And then does it improve efficiency? So the vast majority of chest X-rays will be normal. And if there is a pre-populated report that simply needs validating by the reporting radiologist, and it has a set safety netting already embedded within it, does that improve efficiency? Are we starting to think differently, work differently, that helps our system in crisis? Does it reduce the time from chest X-ray capture to report across the entire patch? Does it improve the time from chest X-ray report when there is a suspicion of lung cancer? Does it get someone to a CT quicker? And if we implement that safety netting, what happens with our referrals? We want to see referrals going up. That's for our responsibility of how we deal with that and how we keep the system efficient. But we know it brings benefits with it. And does it reduce the potential for missed diagnoses? So really addressing many of those barriers in that wider strategy for earlier diagnosis for symptomatic lung cancer. So, with all the excitement there is about lung health checks, at a conference like this, there'll be sessions about lung health checks, and it's brilliant, it really is. But 80% of lung cancers will still be diagnosed via the symptomatic pathway. Chest X-rays are the bread and butter. They will still be the cornerstone of that. So we have to now think about how we optimize the chest X-ray and how we improve the diagnosis through chest X-rays. But we've got to think about this at every level: public awareness, primary care education, direct access, AI and accelerated pathways. They all have to come together if we're going to make a difference. But the chest X-ray is the cornerstone. We've got to do more in symptomatic patients. We've got to improve how well they're reported, improve the speed of reporting, and improve their safety netting. So for us, this is quite an exciting venture. We're doing something different. We're something we haven't done before. We're doing it as a cancer system together. It's a pilot, and we very much look forward to seeing the results of it and reporting the results back of it.